All right, welcome back, everybody. We've got Dr. Spencer Zimmerman, brain health expert with us and a friend of and former student at Parker University. That's why I'm wearing my Parker University Neurology Club t-shirt because we both had, kind of like started breaking our teeth out in Parker back then. Gosh, what was that for you? Graduated
2015.
2013 for me.
2011, you guys are babies.
But glad to have you on the episode today. Really wanted to get into a couple of things that you do in your office that I think is really unique for a lot of different reasons, and I think is catching a lot of getting a lot of attention as an alternative for certain mental health disorders, and that's ketamine. Doc, I mean, let's just break into it. What is ketamine, and why would I take it? What would I do for it?
Yeah, so ketamine, let's go quick backstory. Ketamine initially was used surgically for anesthesia. And then from there, also used postoperatively for pain management, especially for those that couldn't tolerate the opioids. Because normally if you're in the hospital, you've had spinal fusions or other things like that, they're going to give you Dilaudid, they're going to give you morphine drips, things that are really strong. Now, not everyone does well with those, so they would use ketamine. But they were actually exploring ketamine for something else, and they kind of stumbled upon it and they're like, wow, this works really, really well for depression. So for most people out there who now hear about ketamine, you kind of go two ways. You either go 90s, 2000s party craze, using it wrong and illegally, right? Which we can talk about. And then you've got, from a therapeutic standpoint, for depression, anxiety, PTSD, as well as bipolar.
Going back to this question on, when patients come in, do you feel any hesitancy because this was a drug that was popular street drug, right? So it kind of has this like faux pas or kind of illicit aspect to it. When you also make this recommendation, hey, this medication, this treatment could help you. Do you ever face any like hesitancy because of that reputation in the past?
Absolutely. And hesitation really comes from, that's one of them, right? Especially those that are really in their 40s to 60s. They were growing up where people were using it inappropriately at like raves, at parties, and everything else. But then on the other side, where there's the hesitation, it actually tends to be the more, I don't want to say all religious people, but it's almost like 50%, right? Because it's like, a lot of people in religion are taught, don't do anything that alters you, that can alter your psyche. And ketamine at a high enough dose is absolutely going to do that. And so there's that hesitation and the worry of like, hey, if I do this and it brings me out there, that could be bad. Or what if I don't ever come back, because there's ketamine from the way it's been used. But ketamine also gets lumped in with LSD and everything else like that too. That's much more aggressive.
We kind of going on that too. So what is the dosing difference per se to, hey, street drugs that some people might be hesitant with that versus to in the clinic? Is the dosing, a fraction of what the street dose kind of was? Like, how is it dosing wise therapeutically compared to that?
Yeah, I'm not sure exactly what the dosings are, that people are doing at the parties, but you're also looking at what are the other drugs and substances they're mixing with it. But one of the most important things when you're talking about anything in the psychedelic realm is it's all about the environment you're in. It feeds off it. So all of your senses basically become heightened. You'll get dizzy. Things sound louder. If you move your head, right? Like all those movements, all those senses are so altered that you wouldn't need necessarily the same dose that you may do to bring people to a full psychedelic response to still have it go really bad in a party setting where your environment's just out of control.
Yeah, I mean, that makes sense. Frequency, say somebody comes in and you'd mentioned, you said depression, bipolar, let's kind of go through like, what are the things that really respond well to ketamine therapy?
Yeah, so it's used primarily for depression and PTSD are probably the top two. Anxiety, bipolar specifically if they predominate to depression, does really, really well. There's research on it with anhedonia, which kind of falls underneath that depression realm. But there's also people who use it for complex regional pain syndrome, and other type pain disorders. So there's kind of a wide application based upon the mechanism you're going after.
Well, kind of leads me to the
Yeah.
next question. So for our listeners, let's say kind of kindergarten level, how does this work in depression? How does this help brain chemistry and improve neurological function for them?
From a very simplistic level, within the brain, you've got different networks. So one of them is called the default mode network. Now, in different things, it can become hyperactive. So if you think about like an orchestra, it's like, okay, are they playing too loud? Are they not playing loud enough? Either one of those is bad. When they looked at ketamine, ketamine actually helps to restore that balance. And so that's why people who do ketamine, and you'll talk to people who've struggled with depression for years, and after doing a series, you're like, wow, like they're happier than they've ever been. And they've tried every medication, every supplement that was possible. And yet now they're finally getting those results.
So taking it maybe to a fifth grade level, like what would be the mechanism of action, and what receptors is it working on? Which neurotransmitters is it working on? How is it balancing, whether you're saying it's balancing whether it's an overactive brain or an underactive brain? You can use it to balance fairly regardless of overactive, underactive. It brings a balance or stability back into the central nervous system.
Correct. And it works on the NMDA receptors, is where you get a lot of the benefit with ketamine. And because of that, it helps modulate glutamate. So, because in neurology, excitation is not always excitation. Sometimes excitation helps to control stuff. And that's where people get confused when they look at ketamine. They're just like, oh, well, it also impacts glutamate a little bit. It's like, yeah, but it's not that it always revs you up.
Mm-hmm.
So the balance that it does with the NMDA receptor, specifically within the cingulate cortex, is where the main benefits are.
Interesting. Yeah, it's always trying to like explain that aspect in neurochemistry, and sometimes you have too much inhibition of a region that can be bad, because people automatically go to like, oh, like calm things down, take some CBD, or like, but why do I get anxious? And again, kind of having this like, well, sometimes too much inhibition of a very important part that is regulatory to this downstream can lead to excitation and kind of a ramp up of your symptoms, which again, if you're activating a part of the brain that is very critical to a firing rate that makes you feel happy, then it makes sense. So what's a treatment regimen look like? Is it, hey, I need to come in? Is it a month? Is it weekly? Kind of how's that pan out for somebody?
Yeah, it depends on where you go. Most clinics are running 6 to 8 treatments, typically performed at a frequency of 2 to 3 times a week. So it's pretty fast. Most people are noticing, and it depends on how aggressive the clinic is. I always recommend find the clinics that start low and slow, because you can get nausea, right? I get 1 or 2 people a year who's going to throw up. You don't want to throw up at a high dose. Like, don't make that your first exposure. So by about session 3, people are like, hey, you know what? I'm noticing I'm feeling happier. I'm not getting as stressed as I used to be. This isn't impacting me as much. So normally 6 to 8 is a sweet spot for most people. And once again, it's done over that 2 to 3 week period for most.
Yeah, I think that's one thing. Like when you look at kind of how we all know each other, that functional neurology, functional kind of medicine kind of background, but really like the neurology, like I find it interesting because you can go and look into the functional medicine world and it's the same thing kind of there. Like there's some people just think more is better. And I think really the finite art and what our approach and kind of our kind of background philosophy is, kind of the artistry of what we do is finding the dose where they respond, and there's no benefit really blasting 10 feet past it, right? Like, so starting low and slow and finding the sweet spot where they make that positive change versus starting high. One, they get symptoms or more side effects, but 2, like, again, like if you can do a smaller dose and they get therapeutic benefit again, you'd think it would be way more common sense. Like that's how you always want to approach it. But I would just I find that's across the board with a lot of like the functional neurology group. Like it's better to not exceed thresholds and kind of find them and dance around them and play in that world. So anyways, the low and slow, the barbecue.
Yep, because most people aren't going to fault you if you go slow. They're going to fault you if you do it too much, because ketamine's the ultimate trust fall. It's the ultimate trust fall. The more you try to control it, the more likely you're to have a bad trip, a bad experience. So you've really got to let go. If not, you've got people who are anxious and you can actually make them worse. So low and slow really is important.
Well, in terms of in the clinic setting, so like say, you know, how long does this high or this experience last for them? Like, you know, because you can do, I mean, let's go through that. What forms can you deliver ketamine in, right? There's the IV form, there's other options, right, than IV.
Correct. So you've got IV. Those are the clinics that are popping up most places. That's kind of the most popular route. You can also do sub-Q or IM. That works really, really well as also. You've got troches from compounding pharmacies, and troches just kind of put in your mouth, let it dissolve. You even have nasal sprays that you can do. Most people doing it in their office are doing some sort of injectable version of it, though.
Is there an advantage, like one over the other? Advantage, pros and cons?
I mean, you could say, right? So if we say IV, your pro to an IV is like, let's say it's too much for someone, you can just throttle off the IV and can stop. You can slow down the drip. The problem is most of the places in my experience that do IVs, they're not really in there with their patient as they're getting ketamine, right? They put on like a drip. It's timed to 45 minutes. It's always 45 minutes. And I've talked to a lot of them who've had horrible experiences because they just get put on a drip and no one ever comes in. So when it's too strong and they're fighting it, they just get brought through the rest of the way. So IV could be an advantage if you really monitor it. Whereas like if you do sub-Q, I don't know how a lot of people are doing. I'm doing 2 or 3 injections. So let's say I give you first one and then I come back in 15 minutes later and I'm like, hey, yeah, this hit you hard. I can already pull back, right? I don't have to give you as much. And so that's kind of my way of controlling it versus making you overly commit. Because if you just did all in one injection, you can ramp people up really fast and then come down really fast as well, like a roller coaster. And that's kind of, you know, how long it impacts people. You know, most people feel it pretty good for about 30 minutes, maybe 45 minutes. So it's much shorter of sessions than those that, right? Like you probably get lots of people who come in, they're like, oh, I've already done psilocybin. I know I do, right? Psilocybin's a much longer trip. Those doing ayahuasca, much longer journeys, much more aggressive than what ketamine normally is in an office.
And is that like the similar sensation is with psilocybin or ayahuasca? Like, is that what you've been told by people who've been experiencing all those different types of plant medicinals, or however you want to call them?
Correct. It's pretty similar. The difference is they don't feel it's as aggressive, and ketamine, because the way it works, tends to have a little bit more of a calming effect than the other plant-based medicines can tend to provoke a bit more anxiety and also tend to provoke, you know, the gut issues at a much higher level than ketamine does.
Interesting. Is there any change in symptoms? Like if you're doing sub-Q versus IV, I take that's the primary version that you're doing is sub-Q and IV?
Correct. I'm primarily just doing sub-Q.
Okay.
In general, there's no real change of symptoms from one to the other. It's really based upon your dose. So the dose determines the symptoms.
Yeah. Because like, for instance, I've done like NAD, which has, you know, its side effects if you're going at a fairly high dose. I've done an IV and I get, you know, all the symptoms. Feel like I just have the flu for about 30 minutes, and then you hit that B vitamin, it feels great. But like the injectable NAD, it's like no side effects, obviously a much smaller dose, but doing it for like a couple weeks on at a time, and I didn't have any symptoms with it. So just wondering if there was like this one gives people more gut problems, or this one gives people more headache or something like that, anxiety.
It's really about the strength of it and their sensitivity. Normally ketamine's dose starting at 0.5 milligrams per kilogram, and then you work up from there. And it's really just how sensitive you are, because 10-20% are going to have nausea throughout. And a lot of the IV clinics, they'll just give people Zofran prophylactically just up front. Whereas for me, I just kind of ask them and get a feel. But because I'm also checking on them a bit more, we can give it to them, just let it dissolve, and it takes care of it. And then grogginess, I see 10 and 20% are groggy kind of the rest of the day after they do it. And I do know from the patients that have done it at the IV clinics, in general, they are reporting being a bit groggier as a whole than when it's done through sub-Q.
I can imagine.
And obviously because of that, right? Like usually with different providers, from what I understand, like they needed somebody to help them get to the clinic and get home, right? There's obviously, you guys are putting in steps to make sure if they are groggy, they have somebody that's driving home, kind of making sure like there's no lingering aspects to it, which I think that's one of the concerns we had with the patient. It's like, oh, this is built into how the treatment goes. Like there's fail safes. Have you tried it yourself?
Yeah, I'm very clinical though. Like I think I have too much experience with patients, because by the time I ever even tried it, I'd been doing it on patients for 4 years, right? So I've got 4 years of feedback from everyone else. And then when I was finally like, okay, you know what, let's try it. It was almost like you knew too much. And I needed something that I was more naive to. And I just, could let go and could focus on it in that way.
Do you have the patients think of anything, or do you have any type of any type of protocol or anything while a person is sitting in the chair and experiencing this? Like, do you have anything that they're supposed to be thinking about or feeling, or do you have any instruction for the patient when they sit down in the chair?
For most, I don't have them think about anything. I just tell them, look, this is the ultimate trust fall. Ketamine is the driver of the vehicle. Let it bring you where it needs to. Because my average patient, by the time they've done ketamine, they've done 10 to 20 years of counseling with minimal results at best. And I think the biggest reason for that is counseling is very much cognitive based. It's like, okay, let's go through your history. Let's say what cognitively makes sense for us at the age we are at this time we have this conversation. But a lot of the traumas, they're not logical. Like anyone with kids knows 5-year-olds aren't logical. So why do we expect all traumas, all things that altered the way the brain developed to be logical? And so you've got to really just be a bystander and let it bring you where it brings you, and realize that don't fight it, because there are those, they know they've got trauma, they know where it is. And when they get there in their journey, they'll want to fight it and deflect it. But it's like, no, it's like you're watching a movie of it versus re-experiencing it underneath the same circumstances. But if you fight it, you won't heal.
Makes sense. Well, I think kind of to that, like you said, the trauma, a lot of times the PTSD aspect of it, it's not logical in the sense of like, we know the threat or the original like offending trauma is in the rearview mirror, but things that might look or mimic or reflect it still create this, pretty overwhelming response. And so again, it's like, it makes sense. Like, okay, well, yeah, we can talk about it. We can be frontal about it and try to be better at walking our thoughts around it. But it's like, but there's still a subconscious loop that is still making you on high alert for anything that might look like, smell like, bark like that original threat. So having some type of approach that tries to change the neurochemistry of those loops makes sense. So in terms of, do you pair this with anything? Like we talked like TMS, do you do brain therapy? Like, hey, go and see your functional neurology provider the next day. Like, is is there things that really are good for pairing with it? And then even the timings of that to kind of be in sync and get more of both.
Yeah. So to kind of step back, and here's the way I view ketamine, and let's just you move back to depression, bipolar, anxiety, all that. All that is abnormal connections in the brain due to external stressors, right? Things we've put in our body, things we've experienced from the outside world. Ketamine is a signal to the brain to rewire. But
Mm-hmm.
so are your friends. So is your
Mm-hmm.
job. So is the food you're eating, environmental toxins, blood sugar, all of that. So if you want the best results from ketamine, you don't make ketamine a magic bullet. You've got to step back and say, are you set up for success? Like, I'll make people fill out a form. I'm like, who are the 5 people who get your most time and energy? If you can't give them all check marks for being positive people, they've got to get out of your life, or you will not get good results. And if you do, you're going to be calling me back up a month later saying, hey, I lost all my results. And I'm saying, yeah, you remember how I said we were only doing this to help you get to a better spot, but then you needed to take the steps forward. You didn't take the steps forward. I'm not doing this, because ketamine can be a cure, or it can be the ultimate band-aid that you keep turning to. So that's kind of the one really big thing. Next, how often are you actually doing things in life you enjoy? So many people who come in with depression, they can't tell you when they last did something that really brought them joy. And are you shocked when that part of the brain that's meant for survival undoes what you did with ketamine, because you weren't signaling it that, hey, I'm seeking joy, I'm seeking happiness. So those are the most important. But then absolutely, right? You need to know where your blood sugar is. Like, if you're a diabetic and that's eating your brain, that's not going to help you. If your balance and your eye movements look horrible because you've got long COVID, you've had concussions, you've had other traumatic brain injuries, because guess what? While I want you to let go when you get ketamine, you still have to have a healthy frontal lobe to process it on the other side. And the patients I see who will not go through those functional neurology therapies, they don't keep the results as well. They don't.
Yeah, absolutely makes sense.
Well, and I mean, this I find, and again, so a lot of times people in whether it's the integrative, functional med, kind of alternative world, I think sometimes there's a group that still kind of fall victim to doing the same thing that the Western world does. Like, hey, here's this like nutrition product line, and it's the panacea. Just like we vilify medication, like, oh, this antidepressant, like that's all you need to do. It's like, so I feel like there's, both groups are very guilty of playing in the same world, right? And again, and this kind of goes back to it. And I think it's a lot of times as a provider with patients, I feel like, and again, I'm speak to it if you guys feel it too, like people are still kind of looking for that silver bullet. And I think that's the part where it's not like the most resistance, but it's the part where it's like the hardest to kind of like get them to understand, like, you're in this kind of, the center of this with all these stressors kind of honing in on you. And, 5 years went by, you tolerated it. 7 years went by, started not tolerate it as well. Stress, something happened that was kind of an epicenter that pushed that tolerance factor. Now you're a victim of these 5 things. Which one do you remove? One or all the things that kind of stressed and got you there? I think it's hard though, because a lot of people just like, just give me that answer. Like, oh, so I just had like candida in my gut. I'm like, well, maybe, but how did, like, was this opportunistic? Like, what other things allowed this to happen? And I think, do you notice that though? Like, I just had this kind of, I think I saw somebody post, and you kind of just get, and you're like, oh, here we go. Like, take this one thing and it's just going to like solve your life. And I'm like, to me, unfortunately, it's too simple.
Yeah. Searching for silver bullets. I mean, if there's one thing that we do know, there is no silver bullet to health. There is no silver bullet to mental health in particular. And I think, looking for these silver bullets is not the answer, but looking for how can I change my life? How can I change my nutrition? How can I change my exercise? How can I change my sleep habits? How can I change these things all incrementally to have, a synergistic increase in their life? Or the potential to be stuck and stay still, and no silver bullet is gonna make you happy or make you make you feel any particular way for a long time. Because if you don't change your life, there's not going to be a change in the activation of your brain, and nothing's gonna change from from that point, from that standpoint. So what do you see with that type of stuff, Doc?
Yeah, definitely see that, in the same way you see it with people who want to run a business, right? Everyone's looking for the shortcut, what's going to get them there the quickest. The same thing is, I'd say it's even more true in ketamine, because people are they're like, oh, I talked to someone, they did it for 2 weeks and their life has changed. And they just want to do that. Because it doesn't require effort to let someone put an IV in you. It requires effort to do everything that helps you to keep the results and have the best results to begin with. And it actually falls on a lot of providers who they have to do a better job, right? This whole, oh, like there's clinics making millions a year off ketamine, but their patients are coming in every 2 weeks or every month for more and more ketamine at $400 to $600 a pop, and instead of being like, hey, you're not doing this right, I'm cutting you off, right? Like for me, I'll give them the initial little bit if they're a good candidate. And then I tell them, look, here's what I need you to do. And if you don't do it, I won't let you do it any more frequently than this. Like, don't even ask. And if you want to go to another clinic, I just won't see it all. Like, you're done.
Mm-hmm. I guess that's the difference between a drug dealer and a doctor, though, right? It's kind of like, are you going to be a customer for life and I got you hooked, or am I here to help you?
Yeah.
Correct. And I think unfortunately in healthcare in general, like even providers forget that medication is not supposed to be forever. Medication is supposed to be while you're changing your life and changing the things that got you in that place in the first place.
Transition.
But now it's like, we've gotten so used to it that even doctors are sitting here going like, well, once you're a patient for life, and we'll hit you with ketamine whenever you're feeling sad. And it's like that unbelievable that we let it get that far.
And as a provider, a lot of them, they see the finances, right? They're like, oh man, but that's a hit. Like I lose so many patients who are like, why do I have to have a follow-up visit? I'm like, because I'm not giving you more ketamine. Like I haven't seen you in a year. You just can't walk in here and get ketamine like it's Tylenol. But there's a lot of people who want to treat it like it's an over-the-counter med that you can just walk in, get it when you want, walk out. And it's like, no, this is a controlled substance. It can help you, but it can also hurt you. Like, what if the medications you've taken have changed? What if your life has changed? That's not how it should be done. But there's a lot of places, unfortunately, that will let them just come in whenever they want, get hooked up, just like it's an IV bar, and just go on their way.
Or it's like, hey, you're still a raging alcoholic and you've done nothing to kind of change up your environment. Like you're almost enabling a lifestyle that's slowly killing them too. So as a provider, you're like, hey, look, if this trial of care actually gets you in a better cognitive state to get off alcohol or clean your environment up, cut out the negative people, hey, that's a tool to move you through it, to get you stronger, to start kind of, again, getting a true kind of like brain healing, back in place. But again, I think it's one of those things where there's a lot of clinics where it's like, for us, like you got to go home and sleep at night knowing that, your conscious is clean. You're doing everything from a place that's like loving service. I think it's, the whole Parker principle is like loving service is your first technique. And it's right. It's like, that's really it. But there's a lot of places where it's, I think, whether it's stem cells or things that have popped up through healthcare, like, yes, it could be helpful, but there's also places where like they see the dollars and cents. The care isn't necessarily there, and it's just like a numbers game. And that's the part where it's like, I think it harms people getting good results, and potentially like, hey, it gives maybe ketamine and these different things. I don't want to say a bad name, but what if it could have worked for them if somebody's like, look, like we can't let you be pre-diabetic while we do this. Like, why don't we actually counsel you on that while we do this in conjunction? And we get to the same outcome. We're kind of solving and preventing the fallback loop. So, you'd mentioned something about, and again, I like it. I think it's something that we should probably implement some form of it, kind of like writing the major influences, the people you hang around, and answering questions. Are they positive? Because you can almost know the people that are not going to have the good results when you sit down with them. And it's like the husband that's sitting there, or like just kind of like, you know what I mean, pooping on them, trying to get healthy. You're like, and again, and it's the same thing, like, or the you know, the people that do things for others that don't bring them joy, and just like pull energy away from them.
Yeah, the people who identify with that disease, right? It's like, I am bipolar,
Or-
and like nothing's going to change it, or overbearing relationships and things like that, for sure.
Or I kind of, but going through, like, those are two things where, like, I try to tell, like, you got to be selfish for yourself at times, right? Like, do things you love. Like, what have you not done? Like, go back to childhood. Like, what things, if you could go back and be a kid and have no stress in your life, like, what would you go do? When was the last time you did that? And they like, oh, I can't do that. Like, I don't have time to go and like color or do an art class. It's like, you know, it's like, but learn to say no, especially to the people that don't bring you joy. And I think there's such a yes, like, I have to say yes. I have to say yes to people, whether it's people, whether it's like obligations. But I think, like, I don't know who it was, a mentor of ours or mine, like might have been Dr. LaMarche, but somebody back in the day. It's like, you should say no 90% of the time. Like, again, if you always say yes, you get so stressed out saying yes to everything that you do it out of a place of kindness. But I think, again, when it comes to patient care, I think that's just, it's interesting, because I think that is a place where I see people get stuck, is like, they feel guilt if they say no. Then the emotion, if they do say no, the guilt, it has this kind of compounding influence. But I think they got to give themselves permission to be selfish, aka focus on their health, focus on things that make them happy, and basically find the people that actually lift them up versus like pull them down. So, but
Doc, what do you think the future of ketamine looks like? You know, is there, you know, like we are kind of talking about earlier, is it going to go down the route of more like traditional medicine? It's a Band-Aid, or how can we make sure that clinics like yours and clinics that we want to say do things right, do things with intent to truly help and cure the patient, so that they don't have to take medication for the rest of their life? If we're going down that road, what do we need to do to build on that? Like, what do you think ketamine offices around the world should be doing to provide extra support? Like, for instance, you were talking about, you know, certain things that were going to be beneficial in conjunction with ketamine, functional neurological techniques, where we got about 15 minutes or so.
that's right. That's that timer on your watch by accident.
15 minutes or so. I know we're being delicate with your time, but you know, blood work or other, you know, healthcare professionals being involved. Like, what do you see, you know, the world of ketamine turning into, and what do you see your office continuing to provide?
Yeah, so when we look at this, you know, we've got to realize ketamine is very, very trendy. With anything that's very, very trendy, very few people actually care to do it right, right? We look at Ozempic, or, you know, all the different semaglutides. We look at IVs can be highly beneficial, but now you've got IV bars popping up all over the place. And the thing is, are you going to be the Amazon model, which Amazon is all about customer service, right? Anything to please the customer. Or are you going to say, look, we've got experience in this, we've got training in this, I'm going to do what's best for you, even if that means you get mad at me and you're going to walk out of my office, because I'm not going to do something that's not good for you.
Right.
Most of the clinics, right? Like most of healthcare, it's that customer service model. Fine. You want this med for your depression? There you go. Right. You want this? I'll give you an antibiotic. I know it's a viral infection, but I'll give it to you to shut you up so you leave. You know, they let that customer service dominate.
Yeah.
And that's where most of ketamine's it's where it's been. I mean, most of ketamine, what's the requirement to go to a ketamine clinic in most places? You've got a credit card that will swipe for the amount they charge. They don't screen you. They don't say, what's your goal? Are you set up for success? And what we have to do, and, you know, we've already done this in some of the smaller fragments and niches in healthcare, you've got to find that local network around you in your cities or in your state, depending on how big it is, and say, who are the people who do it right And then you've got to support each other, and you've got to go on a mission to grow it from that way. And you've got to find the right patients who want to do it, because guess what? Most of the patients don't want to do it right either. So you've got to say, here's what we do. If this resonates with you, come in. We'd love to have you. But if it doesn't, there's another place. But you've got to be willing to do that and realize that financially, sure, you may make a little bit less money, but you'll still be okay. But as you said, Matt, like, this is about going home and sleeping at night and saying, like, I got into what I do because I saw results. And as someone else's life changes, my life changes too. Like, whenever people tell me these stories about healing from ketamine, I feel so good. Like, it pumps me up. It makes me excited. I hate the phone calls a month later tell me the results didn't hold. I hate those who were fighting it and it just made their anxiety worse. I hate it. But you have to be committed to their outcomes and not to your pocketbook.
Right. And kind of going back and forth, like, let's say even the messages we've had over the last, delayed response to answering the one question, but we kind of been going back, like, when you don't get a result, like, I think that's the other thing, like these kind of ketamine help. I mean, it can be an IV meal, it can be a stem cell meal, it can be a ketamine meal, whatever we want to call it. Again, like, the sheer volume statistics of it doesn't really allow them to go down the rabbit hole where they may, like, hey, why is this person not responding? And trying to be like, again, put the puzzle together, like, because again, so you reached out probably 2 weeks ago and like, hey, like, here's a patient, like, and kind of try, like, is there anything I'm missing? Like, you're going to bat, you're fighting for this patient, you kind of want them to get, you're dying for them to get better, right? And I think that's the other aspect, is like, hey, did we miss anything? And I think that's the other unique part, is like, one, we don't know everything. Two, sometimes, like, there is bias, but you have to be able to step back and be like, okay, the outcome isn't there, but I'm ready to fight for this patient, because I know there's, like, whether it's you or kind of your approach, like, hey, this is probably still the best, like, avenue for them, like, in terms of just advocacy, honesty for them to get better. I think that's the biggest thing, is like, how many times do we have a patient, like, we're sitting like, hey, why didn't they respond to this? Who can we reach out? Like, what are we missing? And I don't think you can say that with, like, the IV spas, the ketamine kind of, like, mills. Like, it's just, those people, like the providers, like you said, like, they don't even come in to check in, like, hey, how's it going? Like, oh, we need to slow this down for you. Like, that doesn't happen. It's just like, no, it's 45 minutes and out, because the next 3 people are booked right on those chairs. So if we do slow it down, like, you're going to disrupt the cash cow. And I think that's the biggest part too, is like, it's just one of those things, like, as a provider in this industry. And I think that's the one thing, is like, you just get frustrated, like, hearing the horror stories of patients coming into your clinic and the things they go through. And again, it's just like, you go home, you got to be able to sleep at night. And I think that's the thing that, your clinic, different clinics, there are good clinics out there. People just have to be willing to kind of not be looking for the panacea, ask these questions so that you find the right providers too. So.
Yep. And as people go through it, it's like, look, man, this isn't about making more money. Because sometimes, right, like, my initial evaluation, it's a bit more than most, but I'm also like, look, I'm not doing a 15-minute evaluation on you just so I can get you in and let's hook up an IV to you or whatever it is. Like, it's worth doing it right to then get the right plan versus determining a plan. Like your doctor would never give you a thyroid medication without running your TSH. Like, they're going to run it. And if it's elevated and your T4 is low, they're like, okay, cool. Here's your medication. But yet people are finding people who won't even do that basic level of being like, hey, you know what? Let's at least evaluate you before we say you need this IV or whatever. I mean, it's just gotten so silly in healthcare.
What would you say, like, how long is your new patient visit? Like, how long do you set aside? Do you have different lengths depending on kind of what they're coming in for?
Yeah. So if I'm doing really focused, I mean, it's 30 minutes with me. That's the minimum. but the average person spending an hour with me, but they can be in there for upwards of 2 hours and 15 minutes just between all the different neurological testing though. So it's try to be really thorough and look at the different angles that are going to set you up for success.
Well, and that's similar to our new patient visits. Like it's an hour and a half to 2 hours. Cause again, we'll go back and look at 6-7 years of labs. Like, hey, we had a patient, kind of neuro dysautonomia patient. It's like, I'm seeing a functional provider. I'm seeing this person. They've done every test and they said it's normal. I'm like, okay. I'm like, let's just upload that all and you need to look at it because maybe it is normal. Maybe they ran everything, but they didn't. Because again, we all have biases. And I think it's just one of those things like, you got to take that time, especially with these complicated patients. And I think it's one of those things where if you had you also need to make sure that you don't let people abuse your time, right? Because there will be people that come in and they may like the idea of getting better, but not necessarily the idea to take all the steps that are necessary. And again, at the end of the day, if they don't get better because they didn't change lifestyle, they didn't fix the insulin signals, they just wanted that panacea, who's at fault, right? Who's the doctor that didn't get them better? It falls on us, right? Like, even though we made us, hey, you didn't participate. I think having that visit set up where, yeah, it might be a little bit more costly, but we're taking 2 hours with you. So we want people who are very serious about taking this step. I think that's one of those things where it's, what else can we do to kind of make sure we don't allow people in that will kind of eat up our time and maybe just, again, be looking for that quick fix. Because again, I think it's one of those things you have to guard against.
Yep.
When you're running like neurological diagnostics, are you seeing changes in neurological diagnostics just by doing ketamine? You're
not going to change eye movements. You're not going to change balance with it.
Yeah.
It's not going to happen. I haven't done enough pre and post with QEEGs. Some of them you'll get some changes and others you don't, but you definitely get some QEEG changes.
That's cool.
But nothing that I've seen that's consistent and predictable. But once again, I need to do more. And then with getting some of the advanced softwares, right? Because when we look at like TMS, Stanford's kind of the leading on that. And they're doing functional MRIs to look at directional flow between parts of the insula and the anterior cingulate cortex. And they're using that to say what predicts results from that. So some of the QEEG technologies are coming out with ways to do it. I need to get that software though to say like, okay, if I really come in those parts of the brain that we see with depression and look at that versus just kind of a global map.
That's pretty interesting. And that's that's in my mind, that's how ketamine's the future of ketamine could be in a combination of functional neurological techniques and functional medicine approaches to, a little bit more complex blood work and really giving it a full approach, if you will, when it comes to the neurological, the physiological, and even the psychological approaches, getting counselors involved or having, guided experiences and those types of things. And it's just the beginning for ketamine. Just hoping it doesn't go down the kind of prepackaged, stop in and get your high, essentially.
With kind of speaking on that and things that tend to make it flow that way, insurance reimbursement, do you think there's ever going to be like a reimbursement model that, again, because my concern once that happens, I feel like that, yes, like there's reimbursement, but I just worry that it's just like, oh, cool, we can get this, bill it, do it, and versus, hey, when I got to get results because this is a cash service, like I need to do this and be efficient with it. So I just feel like it keeps the integrity there too.
Yeah, I mean, there's much longer talk that we'll make shorter, because you already have esketamine Spravato, which is an ARC it's the isomer. Now that one, they do get paid when they do that nasal. Now you've got to be a medical psychiatrist. You've got to actually be part of like a group and be on a list for stuff to be able to do it. And they get paid well. And there's places that do it every single week with people ongoing for years. And they get paid good money from the insurance when they, for that. But the thing is, like, if you got to do it weekly, I'm just like, what are you missing, man? Like, you're missing so much stuff that's impacting them, even monthly. You shouldn't need ketamine monthly. Like, don't need it, right? 6 months minimum, but I've got people who go 1 to 2 years till they get any type of tune up. And then you get others who don't need any at all. So it really depends on what happens. And my biggest worry with most of because ketamine's the wild, wild west, just like a lot of the IV bars, the only difference is ketamine's controlled, is they make it to a point where they say only licensed psychiatrists can do it. It's going to be hard to get people in that actually need it. And then when you do it, let's face it, I don't like psychiatry, right? They mismanage more patients than I've ever seen with multiple antidepressants, anxiety meds. You're just like, look, they've greatly increased your risk for dementia. And you've got serotonin syndrome because each new provider you go to keeps adding new meds. No one will stop any of the other meds that someone put you on. And if that's where it goes to, we're going to hurt a lot of people. But the people doing ketamine, they have to increase their standards and not be a mill. And they have to put patient results first, because in my opinion, maybe they tell me I'm wrong, they probably would, but I view it from an outsider as they care about money. They don't, your results are secondary.
Yeah. Well, one of our very, we've been on about 10 years almost as business partners, and we were both sitting in on this patient, Linda. I mean, I remember she saw a psychiatrist from and again, like, it's like the second or third patient where you're going through their intake and it's like the same psychiatrist, and you're looking at the amount of meds, and it's like 10 different, like, dopamine, serotonin, like GABA, like all these different meds. And she's still like 3 out of 3 for symptoms for everything that these medications are supposed to be handling. Then you kind of look and you stare at her as she's chewing on her face. And you're like, have you ever been diagnosed with like a movement disorder? And she's like, yeah, actually a month ago, I saw my psychiatrist, and yeah, he told me I had tardive dyskinesia. It's like, no shit. Like, yeah. What did he do about it? Oh, nothing. I'm like, again, like, and you're just sitting there. And again, so I have the same sentiment towards sometimes that some psychiatrists, like, again, like, it's just crazy, the neglect in terms of like, I mean, again, cool, like, how permanent do you want that to be? And you're just sitting there like, oh, okay, great. Like, how, and so I think we got off a call with, like, I think called an OB friend that's integrative. Like, have you heard of this doc? Like, you're kind of pissed. Like, this patient that we want to help, you're seeing them be mistreated, but they're kind of like, the psychiatrist is kind of like the god in terms of psychiatric meds. Like, it's a harder voice to be able to go up against that and advocate. And you're sitting there like full wall on, knowing that she's got tardive dyskinesia and didn't pull any of the meds that might have been like triggering it. But it's just wild.
Yeah. And a lot of them get scared, like whenever I do TMS or ketamine, traditional psychiatry is like, no, you just keep them on the meds they're on, no matter how good they feel. Whereas people come into me so I can help them get off as many meds. And if they've got a psychiatrist who doesn't support them, they'll try to scare them and be like, but look at all this improvement you saw. I'm like, don't take credit for this. You've had them on those meds for 5 years. You don't get credit for what's happened over the past month. And I've had some of them, I've told them, like, look, your brain fog will not resolve the rest of the way because of the meds you're on. Your fatigue, guess what? It's not either. Don't expect it to. You've got chemical warfare going on. It's not going to happen.
Yeah, you're waking. I mean, another, like, 2 weeks ago, somebody, former NHL player, like, who knows how many concussions, just kind of like nonchalant, like, here's a benzo for you. And just sitting there like, would there have been another kind of medication? Again, not trying to even be anti-medication. Like, would there have been a better medication to start with for a nerve pain? Like, just something that might have been like a safer approach, or conservative care first. Like, hey, go see this person, do whatever you can to not need this med, especially given your history. So yeah, it's just crazy.
Yeah.
But well, let's
I know we're being sensitive on your time. We're probably getting towards the end here.
Got a shameless plug. You have a book that came out what, a couple months ago, a month ago? Remind me here.
A couple months ago, yeah, back in October.
All right, so not so
Not
not
less
for 5 months. So
A few months, yeah.
tell us what's the title of the book?
Yeah, so it's Brain Reset, 7 Steps to a Healthier Brain.
Awesome. What inspired you to write it? I mean, probably some of the stuff we talked about, but in kind of what was your biggest drive to like, hey, I got to publish this?
So my biggest drive, is I see all these patients for all these complex issues, but no one had ever reviewed foundational stuff with them. And I don't actually enjoy teaching all the foundational stuff like, oh, here's what you should do with, basics of nutrition. It's like, look, you should have to pay me for that. Just read the book, and then when you've got the foundation, now we can go fancier. But I view health like a house. Everyone wants to skip the foundation, the framing, and they just want to go straight to like, oh, here's the chandelier, here's the quartz and the granite. It's like, no, it doesn't work that way.
Yeah.
So that's why I wrote it.
Beautiful. How do they find it? So do you have a website, a landing page, Amazon? Like what's a way that they can kind of go find it if they want to purchase a copy?
Yep. If you want to get the book, just go to Amazon. That's where you can find it.
All right. Well, Doc, I appreciate you jumping on. Any other kind of last thoughts? You're all good. Gotta go help people.
Yep. Thanks for having me. And, just biggest thing, as we've said multiple times, is don't look for shortcuts. Look for doing it right. It will make things easier in the long term and cheaper too.
Yeah. And again, like the foundation aspect, like blood sugar, basic oxygen, fuel delivery may not seem sexy, but you can't like push your way through those things and skip to the chandelier and the granite. Because again, if you don't have a counter to put that granite on, things are crashing. And I think that is like kind of where, we're like, oh, we need somebody to talk about nutrition. Cause like for us, we're like, man, like this is basic. Like again, by the same point, for so many, it's not. So that makes sense. It's a very good idea to have a book or some preface to kind of get people to meet you where you can really jump in and dial in the more specifics. So anyways, I appreciate you jumping on.
Thanks, Doc.
We'll talk to you soon.